can blue light.
Good afternoon, namaste everyone. Welcome to Health and Wellness session number 6 on pancreatic cancer. Thank you for joining the discussion on diagnosis and current treatment options for pancreatic cancer. To all our Facebook and YouTube viewers who may have additional questions to today's guest speakers, please drop your comments in the Facebook and YouTube live stream comment section. These questions will be addressed at the end of the session. Now, it is my great pleasure to invite Dr. Sai Veeramancineni, who is an attendee specialized in internal medicine and cardiology, and a longtime devotee of Hindu Temple Society of North America, to introduce our today's speaker, Dr. Sandeep Anantha.
Thank you, Divya, for those kind comments. I have the privilege to present to you Dr. Sandeep Anantha Satyanarayana, who is our guest speaker today. He's a surgical oncologist who specializes in hepatobiliary and pancreatic surgery. He has dedicated his career to caring for patients with complex gastrointestinal and pancreatic malignancy. Dr. Sandeep went to medical school in Mangalore, completed his residency in New York, and hepatobiliary and pancreatic surgery fellowship in Michigan. In addition, graduated with an MBA in strategic healthcare management. He's currently the associate professor of surgery at the Northwell System, Zucker School of Medicine at Hofstra, and the director of surgical oncology at LIJ Forest Hills. In 2019, Dr. Sandeep went to Bangalore to serve in a medical mission organized by MMFC, Medical Missions for Children, where he spent 2 weeks performing surgical procedures in the underserved population. In 2022, he was interviewed by CBS News to educate about pancreatic cancer and the modern treatment options available for patients. While being a great surgeon, has published numerous research papers and achieved several academic awards during his exemplary career. But it's not just his professional achievements that make him special. Dr. Sandeep is very religious and enjoys spending his free time in our temple with his wonderful wife, who's an architect, and his 10-year-old daughter. Today, Dr. Sandeep will be sharing his insights on gastrointestinal tumors and how we can detect pancreatic cancer early. As it is Colon Cancer Awareness Month, it is very important and appropriate to educate ourselves on these topics. Today, so on behalf of the Hindu Temple Society, please join me in giving a warm welcome to Dr. Anantha Sandeep Satyanarayana. Dr. Anantha?
Thank you so much. Everybody have a good afternoon, and I hope this time of 1 p.m. to start this session is not right in front of your lunchtime. So hopefully I don't bore you enough. Hopefully we'll all learn something about colon cancer, being the Cancer Awareness Month, and pancreatic cancer, which is near and dear to my heart. First of all, let me thank the temple leadership, Dr. Sai and Dr. Uma, for giving me this wonderful opportunity to speak to my own temple and my devotees and my community. In addition, thank you for the organizing committee, Divya, Ravi, and the team to putting this together in a flawless fashion. I also want to extend my thanks to the Forest Hills Hospital leadership and my chairman of Department of Surgery, and also an extension of thanks to Stan C. Saji, who coordinated this talk with the Hindu Temple. Let me share my screen. Can you see my screen?
Yes.
Okay. So the Health and Wellness series from the Hindu Temple organization, we'll talk today about pancreatic cancer. So before we talk specifically about pancreatic cancer, let's learn a little bit about what is cancer, what the digestive system cancer is, and what specifically what pancreas cancer is. We'll learn about what is cancer, or the cancer of the digestive tract, the warning signs, the risk factors, and prevention strategies of digestive system cancer, and go in depth with the pancreatic cancer, its epidemiology, the risks, the early signs and symptoms. Once the diagnosis is made, what are the treatment options, including surgery, chemotherapy, radiation, a little bit of outcomes, and what we at Northwell Health can offer to the general public. So what is cancer? Cancer affects 1 in 3 people in the United States, generally speaking. There are many different types of cancer. Cancer can develop anywhere in the body and is named after the part of the body where it started. Cancer starts when the patient's own cells multiply with no control mechanism. So we commonly confuse tumor and cancer in between the terminologies. A tumor is basically a lump or a growth that can be benign or it can be malignant. A benign tumor is usually that grows but does not grow into tissues around them and does not spread into other parts of the body. Benign tumors are not cancer. Malignant tumors, on the other side, is otherwise called cancer, which can grow quickly and uncontrollably. They grow and spread locally and spread through the blood or the lymphatic system to grow into other organs. They're mostly treated with surgery, chemotherapy, immunotherapy, and radiation. So just a brief about the cancer statistics in general. Based on the 2020 data, the estimated new cases of cancer is over 1.8 million and over 600,000 people will die from this disease. The most common cancers are listed here in its order of occurrence, where you can see the colon and the rectum cancer tops the top 5 and the pancreatic cancer tops in the top 10. So the leading causes of death, if you look at the list of the leading causes of all the reasons why people die, cancer is number 2 in the list, very close to heart disease, which is number 1. It's worse than accidents and stroke and respiratory diseases. So the number of cancer patients is on the rise compared to the last few years. So coming to the digestive system cancer statistics, the digestive system starts from the esophagus down to the stomach, intestine, the colon, includes the liver and the pancreas. If you look at the estimated new cases for 2024 reported by the American Cancer Society, the colon and rectum, which is in the top 4, over 150,000 cases that is estimated for 2024, with the death rate, people dying of this cancer is close to 50,000. With an almost equal distribution between male and female. But if you look at the pancreas cancer, although the number of cancer patients diagnosed with pancreas cancer is lower than other organs, look at the number of people who die from this. It speaks to the aggressive nature of this disease. So I think it's valuable for us to learn about this aggressive disease. So what are the warning signs of digestive cancers? Patients need to know, we people need to know, what do I need to look for me to seek medical attention? Frank bleeding in stool is one of the most common signs. Patients who can't eat, indigestion or difficulty swallowing, especially in patients with esophageal or gastric cancer. Most patients experience a change in bowel habits in the last couple of months, which is subtle, but something that only the patient can relate to. It's always important to examine and keep an attention of all our bodily fluids when we excrete, especially the stool, especially when we're talking about digestive tract. If the stool color changes or smells bad or clay colored or dark tarry stool, that's a sign that you need to get checked. The next few that I'm listing here is also symptoms of digestive tract cancer, but more specific to the pancreas cancer. Patients can experience pain in the upper abdomen or in the middle of the back. Upper abdomen is somewhere in the upper part of the belly. They can experience bloating or fullness of abdomen. This is specific, the jaundice, the yellow discoloration of skin and eyes and dark discoloration of the urine is a symptom of pancreas cancer, which is because of blockage of the bile juice. Most patients with cancer, especially the digestive tract, have experienced unexplained weight loss of 10% of their most body weight in the last 6 months or less. So the way we doctors assess the patient's weight loss complaint is we ask them, have you noticed you're changing the size of your closet, changing the size of your clothes. Have you noticed that your clothes have already become loose in the last few months? That's most common way of identifying, because not everybody keep an eye on their weight on a regular basis. And since it's a slow weight loss, it's important to understand that. And most patients experience fatigue or excessive tiredness. So some of the risk factors, we can prevent some of the risk factors that promote cancer, which we at lifestyle changes can follow to minimize the incidence of cancer. If you look at the cigarette smoking and tobacco use is linked to more than 7 cancer types. Excessive alcohol use is linked to more than 3 cancer types. Some of the infections like hepatitis B and C can cause liver cancer. Radiation exposure, especially the ultraviolet light, can cause skin cancer. The diet that we eat, now the diet is rich in meat, rich in highly processed food, smoked fish, pickled foods. They're all increased fat. They're all promoting cancer. And patients who have a sedentary lifestyle and who are obese also are linked to cancer. A little bit about colon cancer. March is the Colon Cancer Awareness Month. This was actually introduced by President Bill Clinton to enhance awareness of colon cancer when he was in office. Since then, every March we dedicate that as Colon Cancer Awareness Month. So colon cancer is one in top 5 cancers in incidence, meaning occurrence, and second leading cause of cancer-related death. The colorectal cancer often begins as a growth called a polyp inside the colon or the rectum. Finding them and removing them in a timely fashion can truly prevent colon cancer. More than 150,000 cases in 2023, which accounts for 7.8% of cancer cases, with more than 50,000 deaths, which accounts for 8.6% of cancer deaths, are reported just from colon cancer. Although the reported 5-year survival rate is pretty good. It's gotten much better compared to the past years, which is close to 65% for all stages. Some of the symptoms that are specific to colon cancer, if the early cancer, they're usually found during screening colonoscopy. We'll talk a little bit of colonoscopy in the future slides, but they usually don't have much symptoms. That's why screening becomes very, very important. They're usually found as an early polyp or an early cancer, which can be removed during colonoscopy itself. Some patients present with abdominal pain or belly pain. Most patients present with a dark stool or blood in stool and experience of weight loss or loss of appetite, which are all, if you think about it, very generalized, vague symptoms that does not affect your lifestyle. So that's why it's important to keep an eye on how things are happening on a daily basis. Some of the at-risk factors for developing colon cancer is advancing age. Especially over 50 years, the incidence of colon cancer is higher in patients who are older than 50. An African American race, patients who smoke, excessive alcohol use, or obese, have a sedentary lifestyle, and certain diseases like inflammatory bowel disease, especially the Crohn's or the ulcerative colitis, and patients who have a family member with a history of colon cancer are at risk of developing colon cancer in them itself. And some of the genes that are listed are also considered risk factors. So that's why screening becomes extremely important. So how are we going to screen? Why do we need to screen? Colon cancer is one of the few cancers that we can effectively screen. So do not wait until symptoms. Studies show that screening tests for colon cancer help find cancer at an early stage and may decrease the number of deaths from this disease. Remember, this is the second leading cause of cancer death. So the American Cancer Society recommends start screening procedure at age 45 who have no high-risk features, no high-risk components. Patients who have high risk, the ones which we talked about in the previous slide, with family history or personal history of colon cancer, or the genes that are modified, or smokers, so on and so forth, they need to start early. That's why it becomes very important for you to have a very close relationship and visits to your primary care physician. The following types of tests are used to screen for the colon cancer. Fecal occult blood test, which is very simple to do, and it can be done during a physical examination at the physician's office. A sigmoidoscopy or a colonoscopy, which is a procedure as depicted in this picture, where a camera is inserted into the colon and inserted all the way into the cecum, all of the colon, which is shown here. while the patient is asleep, done by a gastroenterologist, picks up all the polyps and early tumors that needs to be addressed. Why is early diagnosis important? Why? Why should we do that? It's logic that earlier the diagnosis, better the treatment will be. If you look at the data that's reported, patients who have a localized cancer within the colon, meaning the cancer is in the colon and is not spread anywhere, just 35% of the cases that are detected, and the regional, because the cancer starts in the colon and spreads to the regional lymph nodes, those are 36%. And if it spreads to other organs like the liver or the lung, it's called distant spread. Those are 23%. So if you think about it, if you add the math, over 65% or 70% of the patients who have localized or regional disease, and if you look at their 5-year survival rate, patients who have a localized disease, 91% of the patients survive up to 5 years. And 73.4% with regional, meaning that spread to the lymph nodes and not any other organs, do survive for up to 5 years. Once you have a distant spread, you see how the survival drops from 73% to 15%. So that's why it is very, very important to diagnose this cancer early, ideally when it is localized, but if it is spread to the regional nodes, it's still not worse compared to distant. This will only happen with screening. So once the cancer is diagnosed, what do we need to do? There are multiple treatment options, okay? Colon cancer has come a long way in terms of treating. The step number one, once the diagnosis is made by a colonoscopy, once the diagnosis is made, then you stage them to make sure it does not spread anywhere. Then the next step in treatment planning is surgery. Depending on the location where the cancer is, that part of the colon is surgically removed and the other parts of the colon are attached together, called an anastomosis. It's called a partial colon resection. Nowadays, we perform these operations with minimally invasive techniques, with robotic colon surgery, laparoscopic colon surgery, and some patients still need the old-fashioned conventional open surgery. So this is a picture which shows, the cancer can occur in any part of the colon, and that part of the colon is surgically removed, and the continuity of the colon is reestablished surgically. Some patients also will need other modalities of treatment, like chemotherapy and radiotherapy. Patients who have cancer in the rectum usually require chemotherapy and radiotherapy before surgery and then do surgery. Some patients with colon cancer, especially the ones that are spread outside the colon into the lymph nodes or the other organs, will benefit from colon surgery, which is usually a multi-drug regimen, which is very well tolerated with acceptable complications. The role of radiotherapy in colon cancer is very, very limited in most cases, but in rectal cancer, there is a huge preponderance of evidence to undergo chemotherapy and radiotherapy along with surgery for good outcomes. So, points to remember: educate yourself and others about colorectal cancers. Remember the warning signs. Visit your primary care provider regularly, especially when you're getting close to your screening age of 45. 45th birthday, the best gift you can give yourself is screening test, including a colonoscopy. Early diagnosis is always better. We just saw how the outcomes are. Seek expert care from specialists. Again, visit your primary care provider who can make the necessary referrals. Timely treatment for better outcomes. Don't be afraid of the diagnosis and treatment. Patients do great. Don't be scared about the diagnosis. Seek care in a timely fashion. We have come a long way with treatment options with good outcomes. The reported 5-year survival rate is 65% for all stages. But remember, if you diagnose early, the survival rate can go higher. We talked about pancreas cancer, given today is March is the pancreas cancer month, but I think we should focus more on pancreatic cancer, which is the topic of the day. So if you look at this picture, you can actually locate where the pancreas is. It is more towards the upper part of the abdomen, which is tucked behind the liver, the stomach, and the colon, which is closer to the back towards or to the front. Okay, more closer to the back than the front. So pancreas has three parts. It's called the head of the pancreas, the body of the pancreas, and the tail of the pancreas, which starts close to the midline above the belly button and runs up across the body to tuck underneath the left rib cage into this organ called the spleen. The function of the pancreas is to secrete enzymes and insulin, which help digest the foods. And this yellow dark line is actually the tubing system of the pancreas, which becomes very important down the line, which I'll tell you. So pancreatic cancer, the cancer formation occurs in the glands of the pancreatic duct or the tubing system of the pancreas. Usually, they're solid tumors, which is otherwise called ductal adenocarcinoma or generally garden variety pancreatic cancer. It also has a less aggressive type, which is called the neuroendocrine tumors or cancer. One in top 10 for most common cancer, which is the third leading cause for cancer death. The more common with increasing age, with median age of diagnosis of 70 years. Males tend to have an increased incidence compared to females. If you look at this statistics, which is reported by the American Cancer Society for estimated number of pancreas cases, which is listed in the order of occurrence, pancreas in male and female is down the list here with approximately, if you add them up, is around 65,000 cases per year. But if you look at their estimated deaths, see how the pancreas rises up on the list to become the fourth on the list for males and third on the list for the females, with almost 50,000 people is estimated deaths from the pancreas cancer. It just speaks to its aggressive nature. Some of the risk factors for pancreas cancer: smoking cigarettes increases the risk factor by twofold. Patients who are type 2 diabetes and obesity increases the risk factor, is considered as a risk factor. Chronic pancreatitis in the past, meaning inflammation of the pancreatic gland over and over and over again, most of the time is from gallstones, or it could be because of alcohol. That becomes a risk factor for developing pancreas cancer. Patients who have a family history of pancreatic cancer are prone to have a higher risk of developing pancreatic cancer within themselves. And some of the genes that get mutated, like the BRCA1 or 2, and some of the syndromes that are linked with pancreas cancer. What are the pancreatic cancer signs? How do the patients know? It's an aggressive cancer with very subtle and vague signs. 83% of the adults are unaware of common signs and symptoms of pancreatitis and pancreatic cancer. So some of the signs of pancreatic cancer is indigestion. They're not able to eat food the way they used to. They feel bloated. They feel full quickly. They have new onset of diabetes. New onset. That's important for us to identify. Pale and smelly stools, meaning the pancreas is not working and the foods we're eating, especially the fatty food, is not being digested and is being thrown out of the body, clogging up the toilets. Some patients present with mid-back pain. Remember, I told you, the pancreas is located more close towards the back of the spine than to the front of the abdomen. So patients do present with the back pain. They feel fatigued. Some patients have nausea, vomiting. Most importantly is jaundice. Patients in the location, I'll go over the location of the tumors: jaundice, unexplained weight loss, and upper abdominal pain or discomfort. So some of the symptoms and the signs are specifically based on the location of the tumor. As I said, this is the pancreas, this is the head, this is the body and the tail. If the tumor is located in the head, where the bile duct and the tubing system of the liver comes and joins, which can clog up all these tubing system, can occlude the flow of bile, resulting in jaundice. So patients with the head tumor of the pancreas do present with jaundice. Sometimes they present with vomiting, itching of unexplained etiology. They have a dark urine because they're dumping all the bile in the urine now. They have pale stools. And this could be an early presentation because they're presenting with these symptoms. Unfortunately, patients who have a tail tumor, which is more towards the body and the tail here to the left side, the cancer kind of tends to grow without presenting much symptoms because it's not blocking anything. Here on the head, it's blocking the bile duct. The bile duct is far away here. It's not blocking anything much. They usually present with vague abdominal pain, weight loss, loss of appetite. Unfortunately, the tail tumors are generally a late presentation tumors. How do we diagnose them? a very good history and physical examination, again, to speak to regular visits to your primary care physician to pick up all these subtle changes that your physician sees you and identifies them. Once there is a suspicion based on history and physical, there are blood tests that can be done to identify subtle signs, subtle changes that can trigger to send tumor markers like CEA, CA19, and do some specific genetic testing. If they are elevated, then we can suspect more towards pancreatic cancer and diagnose them based on highly specialized tests like CT scan and MRI scan, which is specifically done to the pancreas, and a PET scan to evaluate for any spread. Once you see a mass or a tumor in the pancreas, then we can biopsy the tumor for confirmation under endoscopy. Once the diagnosis is made, we need to check if the cancer is in the pancreas, or is it spread to the lymph nodes, or is it spread anywhere else. Based on that, you talk about the stages. Stages 1, 2, and 3 are still better than stage 4 pancreas cancer, because stage 4 pancreas cancer has very limited options compared to stage 1, 2, and 3. Once it spreads to the liver or the other organs, it's considered stage 4. There is a specific set of diseases within the pancreas, which is called the pancreatic cysts. We talked about pancreas cancer as a solid tumor. There are fluid-filled tumors in the pancreas as well, which is called pancreatic cysts. They can be benign, or they can be precancerous, or they can be cancerous. Usually, they're detected incidentally or by chance on imaging for something else. Patients go in for an appendicitis and they pick up a small cyst in the pancreas, and that's how they get diagnosed that they have a cyst in the pancreas. They go in for pain of something else, like a gallbladder or something, and then they get a CAT scan, and then the patient's identified to have a pancreatic cyst. So this gives a very, very small window here to identify those patients who can be screened appropriately and try to act in a timely fashion to prevent it to turn from cancer. It makes it very important to seek medical attention with this finding. So we here have a pancreas cyst clinic for surveillance of high-risk cysts. Any cyst that is more than 3 centimeters in size, or it's compressing the pancreatic duct, and has precancerous changes on biopsy, we term them as high-risk cyst. And we keep a very close eye on this cyst versus surgically remove them. It's usually done with CAT scan or an MRI, and sometimes endoscopy with biopsy. If precancerous cysts are diagnosed early, it can be treated with surgery, essentially preventing it from cancerous formation. This is a window of opportunity to prevent pancreas cancer in patients who are diagnosed with pancreatic cysts. So we at Northwell Health Cancer Institute, we have a brand new cancer center in Rico Park, Queens. It's the largest outpatient center, which is over 70,000 square foot. We launched our GI multidisciplinary clinic in January of 2024, offering patients a multidisciplinary care plan, especially to cater for the population of Queens, which is huge in diversity. So we have capabilities of speaking 30 different languages to make them feel home. We have new treatment options through clinical trials, offering novel and innovative treatments in the patient's preferred language. So we have a multidisciplinary team which is centrally focused on the patient to make sure every aspect of patient's cancer care is organized. We have a surgical oncologist, radiation oncologist, medical oncologist, radiologist, pathologist, and all the other gastroenterologists, palliative care specialists, the entire spectrum in one place to help the patient's care journey. So the multidisciplinary clinic in Queens is usually a one-day clinic where patients get to see all their cancer specialists in one day to walk away with a comprehensive care plan. Usually, the patient's story and the history and the tests are all collected before the day. We have a tumor board at the beginning of the day, and the patient appointments happen on one single day, and they walk out with their care plan organized. So right now, if a patient gets diagnosed with cancer, especially cancer like pancreas cancer or colon cancer, the burden of organizing their care falls on the patient and the primary care provider, who is very closely linked to the patient. So the patient goes to the primary care with a GI complaint, then the cancer gets made, then they have to find out where the imaging is, how the biopsies are done, who to see, when to see, how to see, and that'll take time. Time is money in cancer. So we've taken all that out of the patient and put in as a streamlined one single care plan where the patients get referred to the GIMDC clinic and the patients are seen by the care team and a care plan is developed and the specialists and the specialists are all brought on board, and there is a dedicated nurse practitioner and a GI navigator who can help navigate the patient through their entire care journey. The team itself comprises of surgical oncology, which with multi-subspecialists, hepatobiliary and pancreatic, colorectal, thoracic, medical oncology, radiation oncology, advanced gastroenterologist, and other additional services, with supportive services and a multidisciplinary tumor board to discuss the complex cancer diagnosis and the treatment plan. At Multidisciplinary Clinic, we not only have a good clinical team, but we have other supportive team to schedule operations, to talk about survivorship, to consolidate treatment plan, discuss it in a tumor board fashion, and one point of contact to organize and serve the patient with a navigating system. So this is our leadership team with the surgical oncology, medical oncology, and radiation oncology right here in Queens in the Rigobert Cancer Center. So this is the way we can bring patients in. There's a centralized mailbox and a centralized phone number for patients and for providers to refer patients into. Once the diagnosis is made, we need to figure out how are we going to stage them? How are we going to plan the treatment? So the way we do that is in the tumor board that we talked about. We classify them as these tumors. Are they surgically removable? It's called resectable. Are they borderline resectable? Are they advanced, meaning it is touching and involving the major blood vessels? If they are surgically resectable, the next step is to do surgery followed by chemotherapy. If not, we need to do chemotherapy first, shrink the tumor, and then do surgery after. Unfortunately, the tumor is advanced, and surgery is out of question, and we do chemotherapy and radiation only. So the treatment option, especially talking about surgery, it requires a multimodality approach, needs expert level care. Surgery, chemotherapy, radiation therapy, supportive care, nutrition, and pain control. It's just not one thing. It's a whole gamut of things that has to come together to get the best outcome. So surgeries for pancreatic cancer, as we talked about, fewer than 20% of the patients are candidates for surgery because the cancer is usually spread beyond the pancreas at diagnosis. This is just an illustration of what kind of surgeries we do if the patient has a pancreatic head tumor, is to remove that area of the pancreas and the intestine where the cancer is and make necessary connections to the bile tube and the pancreas, which is otherwise called the Whipple operation. This is called the distal pancreatectomy, is to remove the body and the tail of the pancreas, preserving the head. So all we need is a third or a little more than a third of the normal functioning pancreas, and we can survive and have a normal lifestyle with the remaining gland. So we take advantage of that and remove the bad part and leave the good part of the pancreas in the patient's body. So there are many advances in surgical treatment. We have highly specialized centers, fellowship-trained surgeons with minimally invasive techniques, meaning small incisions using video camera or the robot, surgical safety and team-based approach with enhanced recovery pathways to make sure the patient recovers and gets back to their next step in the journey in a very timely fashion. So the newest advancement in the surgical technology is to add robotic surgery. This is a picture of the robot, is how the robot was started in 1999 and how it evolved to the current state of technology where we can perform some of these complex surgeries. I saw have pictures, and these are all the large instruments that we use in open surgeries. And the benefit of the robotic surgery is it's a minimally invasive technique with smaller incisions, have better flexibility than the human wrist to perform these surgeries. I don't want us to think that this is a robot that's doing the surgery. It's not. It's just a tool, As you can see in this picture, there's the patient's abdomen, and the robot gets docked or attached to the patient's abdomen, which is pretty much like a tool. And these are all the instruments that the surgeon has to manipulate by sitting in the console and use that to manipulate the surgery. So some of the benefits of minimally invasive or robotic approach is highly specialized and advanced techniques. We've shown shorter hospital stays. Patients experience less pain during surgery. Suitable patients, especially the distal pancreatectomy, and selective patients who undergo Whipple also can have a robotic approach. They get cosmetically pleasing incisions and scars. These are some of my patients who've had traditional open surgery and some of the patients who had robotic surgery with major surgical resections with very minimal scars. So, post-op period. Usually, the surgery itself has a very low mortality rate, which is close to less than 1 to 2% from somebody having a death experience after a major surgery. But still, surgery comes with some complications like bleeding, infection, delayed gastric emptying, or pancreatic fistula, which is a connection that we make between the pancreas and the intestine. The most complications are short-lived. In the long term, some patients may experience difficulties eating and anorexia and some appetite issues, but most of them just do fine. Coming to the survival of pancreas cancer, it's not as robust as what we want it to be compared to colon cancer, but for all stages combined, the 5-year survival rate is 13%, speaking to its aggressive nature. The 13% looks bad. I'm not going to deny that. But we've come a long way from 3% of survival a few decades ago to 13% now. But again, if you look at the breakdown of where these tumors are diagnosed and what stage they're diagnosed, especially when they're localized or even spread to the regional, if you look at it, 13 and 29% compared to the ones that are diagnosed late, that is 51%. If you look at their 5-year survival, if you diagnose them in a localized stage, they do have a better survival compared to all stage survival. So that speaks to early diagnosis, timely care, and not wasting time between. That's why early detection of the primary tumor is extremely important to improve survival in pancreatic cancer. Once the cancer is removed, and then we have to surveil the patient, we do a history and physical every 3 to 6 months for 2 to years, and then expand it to 5 years. Then we check them with regular blood tests called the CEA and the CA19-9, which are the tumor markers, to evaluate if the cancer is coming back. And we also perform CT scans of the abdomen and the pelvis and the chest every 3 to 6 months up until 2 years after surgical resection to keep an eye and to see if the cancer is coming back. So these are the resources that I've used to create this presentation. And if we need to learn more about what cancer is and what types of cancer are there and what the outcomes are, these are the very useful resources. We here at Forest Hills Hospital, we are a center of excellence for robotic surgery, and we perform complex robotic cancer surgery here. And I would like to thank everybody for giving their time for this presentation here. Thank you.
Thank you so much, Dr. Anantha. It was simply enlightening, I think, your lecture, and just to the point where the general public can understand what is the importance of early detection and getting timely help. You know, actually coming from a background from Indian culture, there was a whole Veda dedicated to health and wellness, which is called Ayurveda. Ayush means longevity, how to live, and what to eat, when to eat, mental and physical activities that can really put you in a stable condition. I think some of those interpretations that I have read are directly related to the development and growth of cancer cells. If you remember, diet is so, so important. You said the early detection of diabetes. Sugar is almost like poison, you know. They call the dementia as the diabetes type 3. And somehow the microbiome, the colon, the diet, everything is connected to your brain and the immune system. So they're interlinked. This knowledge from the Ayurveda seems to be almost an explosion and revolution. If you look at the podcast and the new information online, I think it's extremely important how we should go back to our ancient eating habits, what our grandparents and parents cook for us. The plant-based food is the very popular thing to do now, right? Turning vegan and vegetarian. I think 20 years ago, they would laugh at you if you said you didn't eat meat, but now it's the fashion of the day. Unfortunately, the American diet is called SAD. SAD meaning Standard American Diet, which is fries, burgers, and sodas. So having said that, I think your lecture was such an eye-opener. I have several questions, so I'll start with the simplest one first. What kind of diet would you really kind of advise for the general public to prevent cancer in general, and especially for pancreatic cancer?
Thank you so much for those questions, Dr. Sai. You actually hit the nail on the head. I'm also a culprit of being a critique. When I was a kid, to make fun of home cooked food and try to fancy food that is processed. But as I became more wiser and more knowledgeable, it's realized very quickly that absolutely correct. Fresh, healthy food with fresh ingredients and less processing and less stored foods, less pickled foods, less fatty foods. Switching to a vegetarian or a vegan health diet is very, very, very much linked to decreasing cancer incidence. I got to say that. But that is not the only thing that you need to do. I mean, doing that alone is not going to change the strides towards not getting cancer. That's one thing that will pay off in the long term. That not that alone. You have to cut down your lifestyle habits like smoking,
Yes.
excessive alcohol, sedentary lifestyle. Keep an eye on not being obese, and most importantly, regular visits to your primary care physician, such that they can identify small, subtle changes in a very early fashion.
That is so important, the regular visits to the doctor and focusing on preventive screening. So I would urge and request humbly to all our Hindu Temple members and those who are watching in the audience, Dr. Anantha is right around the corner. He's our neighbor. So please make those visits and try to educate yourselves and get a screening test for colon cancer or pancreas. And I have several questions, so let me go one by one. Would specific blood tests help in early detection of pancreatic cancer?
There is not one specific blood test so far that detects pancreas cancer. It's a combination of things, unfortunately, still. Once the cancer is diagnosed, then we can do multiple genetic tests to see what genes or what genetic mutation the patient had, which could result in pancreas cancer. As I previously mentioned, we have something called tumor markers that we check, but we don't check them to diagnose the cancer. We check them to see if the cancer is relapsed back. So once a cancer is made, there's not one blood test that we can do to identify pancreas cancer.
And also you said smoking is one of the leading cause. How does secondhand smoking influence the same? Also, latest trend in e-cigarettes aid or influence pancreatic cancer?
We know that the first-hand or the second-hand smoke, it's the inhalation of the carcinogens in the nicotine-rich smoke is the mutating agent causing pancreatic cancer. There's not much of literature in terms of e-cigarettes, but again, e-cigarettes has its own health detriment, damaging effects on other types of cancer, but there is no level 1 evidence which proves or links to pancreas cancer.
Is pancreatic cancer a genetic disease only, or can it be caused by diet? I'll just give you, these are like sound repetitious sometimes, but there's a little add-on to it. Can you live without a pancreas? Can pancreatic cancer be prevented? How frequently do we need to get this test done to detect the cancer, yearly or otherwise?
So pancreas cancer is genetic, but most pancreas cancers are diagnosed in a sporadic way. There are some patients who have genetic link to the known pancreas cancer. That being said, that's based on today's knowledge. But who knows, in the next 20 years, we come up with new genetic testing and we can link these particular gene mutations are linked to the pancreas cancer as one of the leading cause. But up until now, it's a sporadic disease, meaning that most patients who are diagnosed with pancreas cancer, they might or might not have somebody else in the family member with a pancreas cancer. And to answer your second part of the question, can you live without a normal pancreas? Absolutely, yes. We've removed the entire pancreas in selective patients. It's called a total pancreatectomy. So some of the side effects of having no pancreas at all requires them to be on pancreatic enzymes to help digest the foods, and they're going to be 100% diabetic. So they're called brittle diabetes. So patients who get total pancreatectomy are 100% diabetic. Other than those two, yes, patients can live without a full pancreas, but most of the time, most surgeries that we do for the pancreas is to remove a portion of it, not the whole thing.
That is very important information. Thank you, Dr. Anantha. Now, screening recommendations for CRC, colorectal cancer in Indian American population. Are there any different standards or just the American Cancer Society recommendations?
So there's not a specific recommendation just for the Indian population. If you look at the recommendations for general American population, it was 50 years, but now they dropped it down to 45. And patients who are at high risk, the ones which we mentioned, who have a family history of colon cancer or who had a previous colon cancer, they have to screen sooner than that. Usually it's 5 to 10 years before your earliest relative. If somebody first degree relative got pancreas cancer at the age 50, then you have to start screening at age 40.
Now, also the diet recommendations, I think we've gone over that. Do you feel that population, meaning our folks who live in India versus living in the United States, I know it works for coronary artery disease, people who have migrated here, the incidence is kind of different depending on the diet and activities and other things. Is there a difference between the incidence, the prevalence, and the treatment modalities, India versus here?
I think one of the things that I have noticed, especially for cancers in India versus cancers here, is the stage of diagnosis and the access for treatment options. The incidence per se, I don't think is any different if you take stage per stage comparison between the two nations. But if you look at the health literacy and to look at the stage that the cancer gets diagnosed, it's usually at a later stage in India compared to here. But still, I think we have to elevate the knowledge and awareness for screening for early cancers here as well. But it's much more in India than here.
I appreciate those comments. Differences between Cologuard versus, FOBT versus FLEX versus colonoscopy for screening. And if you can elaborate on what those tests mean for the audience.
Yeah, I'm a surgeon, so I usually don't do those tests, and I usually get the patients after those tests are done. But just to give a basic knowledge, yes. The Cologuard and the fecal occult blood testing is a simple blood test. The Cologuard can be done by the patient himself or herself in the patient's home and can be sent to the primary care's office for results. Similarly, the fecal occult blood test is done at the primary care physician's office. Basically, what they are testing for is blood cells and some tumor components that can sometimes be shredded into the tumor. So those are indications that you have to get a colonoscopy sooner. So if your Cologuard or fecal occult blood test is positive, even though you don't meet the criteria for screening at an earlier age, it's an indication to get a colonoscopy sooner. So it's a step to push towards colonoscopy. It's not a replacement.
Okay, but the best thing is to just do a colonoscopy. Even sigmoidoscopy is kind of shied away these days, right?
Yes, we limit colonoscopy, very limited patients, but colonoscopy, a full colonoscopy to evaluate the entire colon is very important.
That's a very good answer. what are the chances of a pancreatic cyst becoming cancerous? I think they must have missed it during your presentation.
So not all cysts turn into cancer. So I don't want us to walk away from this presentation thinking we got to diagnose a pancreatic cyst that's going to turn into cancer and freak out. So not all patients who have pancreatic cysts do turn into cancer. A very, very, very few number of patients who can have these high risk cystic lesions can turn into cancer. But if you look at that particular patient, and if you've removed that cyst in a timely fashion, they pretty much can say, I beat pancreas cancer. Not too many people can say that. So that's why it becomes important once a pancreatic cyst is diagnosed to seek medical care to see what the next steps are. See the expert. And once the expert sees it, and if it is high risk, then there's a specific protocol that we follow. So largely speaking, not all cysts are cancerous. Some cysts can turn into cancer, but the incidence is less than 10 to 15% that can turn into cancer.
So would you recommend removing all cysts?
We don't remove all cysts, but we have to keep an eye on all the cysts, meaning we have to surveil them to make sure that they don't turn into cancer. And if they do start misbehaving, we got to act quickly.
If surgery is not a possibility, what are our other treatment options? I think you actually explained those in great detail, but if you can just summarize for the listeners.
Yeah, patients who are diagnosed with pancreas cancer, the best outcomes are for patients who get surgery, chemotherapy, and plus minus radiotherapy in selective cases. They have the best outcomes in terms of survival and cancer-free periods. Patients who cannot get surgery, or patients who don't want surgery, which is not a smart thing to do, or surgery is not an option because it's spread already, then the only other options they have is chemotherapy and radiation. Some patients also qualify for immunotherapy as well. And again, if the patients can get surgery, then there is supportive care systems to alleviate their symptoms like pain, digestive systems, diarrhea, which can limit their lifestyle. So that's why we have a supportive oncology team to address those concerns.
I was so impressed, Dr. Anantha, when you showed us the multidisciplinary approach to the pancreatic cancer. And actually, just right here in Rego Park, it is so useful to our temple members, to visit that. Not that I want them to go there for unnecessary things, but it's such an important thing. I think the general public should understand what a multidisciplinary approach means. It's not just the surgeon. Again, in breast cancer, that is so crucial.
Yes.
In GI tumors also, the surgical oncologist, the medical oncologist, the social worker, the medical person, everybody together, I think, make a big impact on the survival and the way they can, if for distant and metastatic cancer, it becomes so crucial. I think that was very impressive. I think I would encourage our members from the temple and also from all aspects. You said there were like about 5 or 6 different groups or languages that you speak over there. Hindi, Bengali, I saw that.
Yeah, we have
Mandarin, yeah.
Yeah, we have over 30 languages that can be spoken in the cancer center itself, either as a direct person to person, or we have an interpreter service where the patient feels that the communication happens in their language rather than being forced upon in English. So the questions can be asked in their own language, and they get heard in their own language.
That is such a blessing. Now, since you finished the lecture to the point on time, I like you to, because I would always say, even though I'm a physician, I would never want a robot to operate on me. Can you just kind of give us a little more insight into robotic surgery? I know that's your specialty. Since we have a few minutes,
Yes.
I know you did explain what it looked like, and the surgical incisions are so minute, and the recovery period is really quick. So just a little to make put the minds at ease what a robotic surgery means in general, and especially in your field.
No problem. Thank you for that opportunity. So it's a very common question that most patients come and ask me is that when you say robotic surgery, are you not going to be the surgeon? Is it the robot doing the procedure? So I think it's a lack of better terminology. It's called a robot, but it's actually an advanced surgical tool where we actually put instruments into the patient's abdomen, and the instruments just stay stationary until me, the surgeon, moves the instrument myself. It's pretty much the surgeon doing surgery with minute instruments, if you can think about that. So you're trying to make those minute moves inside the patient's abdomen to move the structures with the instruments instead of you putting your bare hands in it. It's pretty much an advanced tool.
Actually, bare hands are pretty clumsy now that in retrospect we can realize, we can pinpoint. But I know electrophysiology can be done from a remote room, people
Yes.
are studying the electrophysiologist. So I know with AI, I think it'll be another revolution in the surgical techniques, I guess, in the coming years.
Yes, at least for 2024, the surgeon is in the operating room right next to the patient with the robot acting as a tool to doing surgeries. They have talked about, we have talked about or even explored into remote surgery as an option where the surgeon sitting somewhere else. In further countries, I think there were a couple of cases in Australia where they did the robotic surgery with the local team there with the patient, and the surgeon in a remote facility doing a complex surgery that they didn't have capabilities of. But we're not there yet for technology use, for legal purposes, and the direct responsibility of the patient. We're not there yet. I don't foresee that happening in the future.
That sounds very interesting. Do you see an application of AI in the field of surgery?
Absolutely. Absolutely. The AI is going to be to aid the surgeon with the necessary tools and information rather than take over. That's where we see, especially to guide the surgeon to make the necessary steps in certain places to prevent complications, which is a human error sometimes. That's where the AI comes in picture.
Okay, and then just now another question came up. We have a few minutes, so let me ask you this. Is there a test such as swabbing would diagnose if an individual can possibly get cancer?
Swabbing, unfortunately, is not there yet in terms of diagnosing a cancer, especially the colon and the pancreas. There isn't an effective screening method for pancreas cancer yet. But if you think about it, if you put CT scan every 3 months for patients as a screening method, yeah, we are absolutely going to pick up a cancer at a very early diagnosis. But you're exposing the patient for so many CT scans, so much of radiation for a benefit, which might or might not be seen for that particular patient. And also to think about in a global perspective, how much of resources are we using to screen a cancer? So that's why there is very few cancers that we can screen. Sometimes like skin, breast, colon, and those are the ones that we screen most of the time.
Since you've gone to India, to Bangalore, do you think in India, I've noticed my observation, in most cancer centers, they almost overutilize, I wouldn't say abuse, PET scans. Do you think there's a place for PET scan?
Yes, there is a place for PET scan, which is selective, but not for every single patient diagnosis. I think, Dr. Sai, I feel the same as we overutilize PET scans in India because most and all patients, since they have access to getting PET scans without any approvals, they just get it. Just for the question of safety, I want to make sure. But I think it is overutilized in India compared to here. But there is selective value for PET scans, especially if you are suspecting cancer that is spread outside of the organ. Because we only do tests not only to ensure, most of them is not for ensure. If it changes the plan of care, we need to do a test. Because if you do a PET and if you see a spread, then there's no need for surgery. So that becomes a huge deal.
Yes. Absolutely. If something helps you to change your management, it becomes very important. Exactly. So I think that ends our session for today. Dr. Anantha, if you stay on for a couple of minutes, on behalf of the Hindu Temple Society, I'd like to actually make a quick comment before Uma comes in. I don't know how much you know. I know you visit the temple regularly. It's almost like an institution. I call it a university. We have Saturday Partishala classes, Saturday classes, the youth, Akshaya group, and for senior citizens, and the health and wellness. And we used to also have, like before the COVID, 3 health fairs during the year, which really our population enjoyed and got benefit out of. Besides being the best run place of worship outside India, okay? Hindu Temple Society is extremely well run. And what you see in Dr. Uma Mysore is very, very rare. She's like a one-man army or one-woman army, I should say. So on behalf of Uma Mysore and the Hindu Temple, Uma, would you like to come on?
Yeah, certainly, Sai. Thank you. I don't know why you need to make these comments. But
No.
Dr. Anantha, thank you very much. I really appreciate you making the time and giving such an important information, especially among Indians. You know, I have noticed this colon cancer is somewhat neglected because they always say vegetarians don't get colon cancer. This is somewhat ill-advised. I don't know why, who started this, but anybody I speak, oh, don't worry, you know, you're a vegetarian. Vegetarians don't get. So I think this kind of misconceptions need to be removed. Everybody has to know how it can be diagnosed and what needs to be done to be treated as well. And I think when Stancy called me and said that you are there for this, I was very quick in accepting this because this is one aspect where our people were totally unaware of. That's when I discussed with Dr. Sai also. So I think it turned out to be excellent, really. And the most important is your presentation was simple, but yet
Yes.
totally with lots of information, but made it simple for people to understand. You know, because otherwise it's only the physicians who follow. We don't want it like that. We wanted the regular people to understand, make use of it. And if they need to go for checkup, they understand where to go, what to do. And this is the main reason why we have this health and wellness, not just for lectures, but for utility by our devotees. So thank you, and we look forward to having you again. And certainly wish you the very best, Dr. Anantha.
Dr. Uma and Dr. Sai, I've said it in the beginning, but thank you so much for inviting me here. It was such an honor. This is going to go on the top of my CV line as I was invited to give back my community a little bit of what I can offer. And, I always look forward for more opportunities to be part, not only for future lectures, but also be actively involved in temple and give back more to our community.
Surely, absolutely, absolutely.
I did encourage you, Moma, the other day during the rehearsal. I said, Dr. Anantha, why don't you get more involved in the temple activities that you come regularly?
Yes.
And he was happy to do that. He will be speaking to you about that.
Very good. Excellent. Excellent.
Exceptional presentation, like Uma said, to the point, and everybody could understand, whether you're a medical person, non-medical person.
Right.
Wonderful presentation.
We've had presentations in the past, they've all been good, but only who are in that field, in medicine, could appreciate it. But average people, some of these terminologies, it goes about somebody's head.
Yes.
But I think this is excellent. This is the way it should be for when we do this kind of thing. Thank you. Thank you so much.
Thank you so much. Stay on for a couple of seconds. Is bringing on Divya.
Okay, Divya.
Thank you, Dr. Sai. Thank you, Dr. Anand, on behalf of the Hindu Temple Society of North America. It was definitely a very informative session for me, new to this kind of field. It's a pleasure to have you here and provide us some awareness to the community and address some preventable risk factors to this topic. Before we end the session today, I would like to announce some of the upcoming events in the temple. We have the Holy Festival that will be observed on Sunday, March 24th. And then we have the annual Composers Day that's scheduled on Sunday, March 24th as well at 10 a.m. and onwards in Saraswati Hall. On April 9th, Tuesday, will be beginning of Lunar New Year, Chandramana Yugandi, and also Sri Ramanavami Utsavam. And it will be ending on Tuesday, April 16th. So that will be concluding our upcoming events. Thank you very much and all the very best. And stay tuned for more health and wellness sessions.
Thank you, Vidya.
Thank you. Thank you. Thank you, Divya. Thank you.